Ever find yourself trying to follow along when someone mentions a complex medical thing like heart failure and you're nodding, but you don't really get it? Or maybe
Yeah.
you just want to properly understand something important without wading through medical journals. Well, you're in the right place. Welcome to the deep dive. We take solid source material and, well, we unpack it for you, get you the essentials. Today, we are tackling a big one, heart failure. It affects so many people, and honestly, it's often misunderstood. Our mission, to really get into the types, the causes, the symptoms, how it's diagnosed, and crucially, how it's managed today. We're using some great medical sources here. Okay, let's unpack this.
Yeah, and it's striking just how common and frankly how intricate heart failure really is. It's not just one thing. It's a syndrome and it impacts life in so many ways, sometimes ways you wouldn't expect. Getting the information right is, well, it's pretty vital.
Okay, first things first. Let's clear up that big misconception. Heart failure does not mean your heart has stopped working completely.
Exactly, that's critical. The sources define it as a clinical syndrome. Basically, the heart muscle just can't pump enough blood to keep up with what the body needs. It's struggling, failing to do its job effectively.
Struggling, okay. And our sources say there are different ways it struggles, different types.
Precisely. We can break it down. First, think about which side of the heart is most affected. You've got left-sided heart failure, super common, often caused by things like coronary artery disease, blocked arteries, or maybe years of high blood pressure, or issues with the heart valves like a tight aortic valve, or maybe a leaky valve causing backflow. And sometimes it's just a weaker heart muscle, what we call cardiomyopathy. The key thing for left-sided, remember L for lungs. That's where the fluid backs up, causing breathing problems.
L for lungs, got it. And the other side.
Then there's right-sided heart failure. And interestingly, the number one cause of right-sided failure is actually left-sided failure already being there. The strain just carries over. But it can also start on its own, maybe from lung diseases like COPD or pulmonary hypertension. For right-sided, think R for roads, the body's main veins. Fluid backs up systemically, causing swelling in the legs, abdomen, that kind of thing.
Okay, left versus right makes sense. But there's another distinction too, right? Something about ejection fraction.
Yes, absolutely crucial distinction. It's about how well the heart squeezes. So you have heart failure with reduced ejection fraction, or HFrEF. HFrEF. This is what people often think of a weak heart muscle. Systolic dysfunction. It can't contract forcefully. A heart attack is a really common reason for this. You'll see a low ejection fraction number on tests, maybe hear an extra heart sound, an S3 gallop.
Okay, reduced ejection fraction. HFrEF, what's the other one?
The other is heart failure with preserved ejection fraction, or HFpEF. HFpEF. And this one's different. It's diastolic dysfunction. The heart muscle is often stiff, maybe thickened. It can actually squeeze, okay, the ejection fraction might be normal, even high sometimes, but the problem is it can't relax properly to fill up with blood between beats. Think long-term high blood pressure, especially in older folks. That's a classic cause.
Stiff, not necessarily weak. That's a key difference.
A massive difference. And knowing HFrEF versus HFpEF is absolutely fundamental because the treatments can be quite different.
Okay, so here's something I found really interesting in the sources.
Mhm.
How the body tries to help but ends up making things worse. Can you walk us through that?
Ah, yes, the paradox. It's like the body's own coping mechanisms turning against it over time. The sources lay out a kind of three-stage process. First, stage one, there's some kind of initial injury, a heart attack maybe, or just that chronic strain from high blood pressure we mentioned. This injury makes it harder for the heart to pump effectively. So maybe it's not filling right, maybe it's pumping against too much resistance, or maybe the muscle itself is just weaker. Bottom line, cardiac output drops.
Okay, so the heart's struggling. What does the body do?
Stage two, compensatory responses kick in. Your body senses it's not getting enough blood, so it kind of panics. It activates systems like the RAAS, the renin-angiotensin-aldosterone system, which tells the kidneys to hold on to salt and water to boost blood volume and pressure. Your sympathetic nervous system, the fight or flight response, ramps up too, making the heart beat faster and harder. The heart muscle itself even starts to change shape, remodeling, trying to adapt. And importantly, in the short term, this actually helps. It keeps blood flowing to your brain and organs.
But there's a catch?
There's the catch. Stage three, decompensation. Over the long haul, keeping those compensatory systems switched on becomes, well, maladaptive. It's harmful. All that salt and water retention leads to chronic fluid overload. That constant adrenaline rush puts more strain on the already struggling heart. And the heart remodeling eventually makes the chambers dilated and weaker, especially in HFrEF. It becomes this vicious cycle. The weaker heart pumps less blood to the kidneys, which makes the kidneys activate REAS even more, holding on to more fluid. It just spirals.
Wow, a vicious cycle indeed. So, given all that internal chaos, what does someone actually feel or see? What are the telltale signs?
Well, for the pulmonary symptoms usually linked to that left-sided failure L for lungs, remember? Shortness of breath or dyspnea is really the classic one. It often starts subtly, like only when you really exert yourself. Then maybe you need extra pillows to sleep, or you wake up gasping eventually. It might happen even at rest. Sometimes there's a chronic cough, maybe with some pink, frothy sputum if it's severe. That's fluid in the lungs.
Okay, breathing problems. What about the right side of the roads?
Right, the systemic symptoms. More from right-sided failure. Peripheral edema is a big one, that's swelling in the legs or ankles that you can press and leave a dent in. People might notice sudden weight gain, which is actually fluid. You might see bulging neck veins, that's called jugular venous distension or JVD. And because fluid backs up into the gut and liver, people might lose their appetite, feel nauseous, or even have abdominal swelling.
And the sources mention some less obvious symptoms too, things you might not immediately connect to the heart.
Yeah, absolutely. Things like just feeling really fatigued, weak all the time, sometimes needing to pee a lot at night, nocturia, and even cognitive issues like memory problems or confusion, especially in more advanced cases. It's a whole constellation.
So when someone comes in with these kinds of symptoms, what does a doctor look for on examination? What do they actually hear or see?
Good question. So, listening to the lungs, they might hear crackles or riles, kind of like a bubbling sound that's fluid in the air sacs. Maybe some wheezing too. Breathing might be fast.
And checking elsewhere.
On the peripheral exam, besides that pitting edema in the legs, they'll check the neck veins for that JVD, that elevated pressure. If the heart failure is really severe, affecting blood flow out to the body, the person might look pale, maybe sweaty, and their hands and feet might feel cool. We sometimes call that the cold and wet presentation. It signals poor perfusion.
And listening to the heart itself. You mentioned extra sounds.
Exactly. In HFrEF, that systolic kind, you might hear an S3 gallop. It's like an extra sound after the normal lub-dub, sort of a lub-dub DUB. It happens when blood rushes into a ventricle that's already overfilled and dilated. They might also feel that the main heartbeat, the apex beat, has shifted outwards because the heart's enlarged. And you can sometimes hear murmurs if the valves are leaky because the heart has stretched. In HFpEF, the diastolic kind with the stiff ventricle, you might hear a different extra sound, an S4 gallop, which happens just before the main lub.
Okay, so you've got the symptoms, the exam findings.
Yeah.
How do doctors actually confirm the diagnosis and figure out which type it is? What are the key tests?
The absolute workhorse, the diagnostic test of choice usually, is the echocardiogram. It's basically an ultrasound of the heart. It's incredibly valuable. It shows the heart size, how well the walls are moving, how well it's squeezing and relaxing, and crucially, it measures the ejection fraction, that EF percentage.
And that EF tells you if it's HFrEF or HFpEF.
Primarily, yes. A low EF points strongly to HFrEF. You'll often see thin walls and a dilated ventricle too. If the EF is normal or even high, but the patient clearly has heart failure symptoms and the echo shows thick, stiff walls and maybe a small chamber, that points towards HFpEF, the diastolic dysfunction. The echo can also sometimes reveal the underlying cause, like valve problems or signs of a past heart attack.
So the echo is huge. What else?
Routine blood tests are important, checking kidney function, electrolytes, liver function, thyroid, complete blood count. And an ECG, or electrocardiogram, is standard. It looks for abnormal rhythms, signs of coronary artery disease, or heart muscle thickening. But ECG findings alone are often not specific enough for HF.
You mentioned a blood test earlier, BNP.
Right, brain natriuretic peptide, or BNP, and a related one called NT-proBNP. These are hormones the heart releases when it's stretched or under pressure. If the levels are high, say BNP over 100, it makes heart failure much more likely. But it's actually really good at ruling out heart failure if the level is low. High negative predictive value, we call it.
But you mentioned a catch with treatment.
Yes, we'll circle back to that, but one of the key drug classes we use now, ARNIs, actually increases BNP levels because of how it works. So once someone's on that drug, you can't really rely on BNP changes to track if their heart failure is getting worse. It's a bit tricky.
Good point. And finally, there's a classification system, NYHA.
Yeah, the New York Heart Association functional classification. It's just a simple way to grade severity based on symptoms during activity. Class 1 is basically no limitation, Class 2 is slight limitation, Class 3 marks limitation with less than ordinary activity, and Class 4 is symptoms even at rest. It just helps gauge how bad things are and guides therapy.
Okay, so diagnosis clear. Let's talk management. This seems like where things have really advanced, especially for HFrEF, the reduced ejection fraction type.
Absolutely. HFrEF management is quite well defined now, and it always starts with lifestyle modifications. This isn't just advice, it's critical. Things like weighing yourself daily, a sudden jump, can be the first sign of fluid building up. Strict sodium restriction is key, usually aiming for under 3 grams a day, maybe even less. Definitely avoiding high salt foods. Fluid restriction sometimes, but usually only in really severe refractory cases. Plus, stopping smoking, limiting alcohol, managing weight, all foundational. Patient self-management is huge.
And then the medications, you mentioned 4 pillars.
Yes, for HFrEF, particularly NYHA Class 2, there's this concept of guideline-directed medical therapy, or GDMT, built on 4 key drug classes. These have dramatically improved outcomes.
Okay, pillar number 1.
Pillar 1 targets the angiotensin system, and the star player here now is usually an ARNI angiotensin receptor neprilysin inhibitor, specifically sacubitril valsartan. It's generally considered more effective than the older ACE inhibitors or ARBs. It works in 2 ways. It blocks the harmful angiotensin system like an ARB does, and it inhibits an enzyme called neprilysin. By inhibiting neprilysin, it lets the body's own helpful natriuretic peptides, like BNP, stick around longer. These peptides help relax blood vessels and get rid of sodium and water, so it's a double benefit.
And that's the drug that affects BMP levels.
That's the one. Because it boosts those helpful peptides, BNP levels will be higher in patients taking it, so you can't use BNP to monitor them in the same way. That's important for patients and doctors to know. Big trials showed ARNIs cut death and hospitalization risks significantly compared to ACE inhibitors. But, there are contraindications, pregnancy, history of angioedema, and you can't take it within 36 hours of an ACE inhibitor. ACE inhibitors and ARBs, so sartans, are still vital alternatives, though.
Okay, RNI or ACERB, pillar 2.
Pillar 2 is beta blockers. Specific ones like carvedilol, bisoprolol, metoprolol succinate. These are non-negotiable for most HFrEF patients. They counter the damaging effects of that chronic adrenaline overdrive, slow the heart rate, reduce remodeling, and actually improve the heart's pumping function over time. Huge mortality benefit, around 35%.
But you mentioned being careful with them sometimes.
Right. While they are crucial long-term, if someone is having an acute flare-up, an acute decompensation, especially if they're very fluid overloaded or have low blood pressure, the beta blocker might need to be temporarily reduced or even held. You restart it carefully once they stabilize.
Got it. Pillar 3.
Pillar 3. Mineralocorticoid receptor antagonists, or MRAs. Drugs like spironolactone or eplerenone. These block aldosterone, another hormone involved in that maladaptive RAAS activation. Aldosterone contributes to sodium retention and fibrosis, or scarring, in the heart. So blocking it provides another layer of benefit, reducing mortality further. Main thing to watch with these is potassium levels. They can cause hyperkalemia. And spironolactone can sometimes cause breast enlargement in men, gynecomastia. Eplerenone is less likely to do that.
Okay, that's 3. What's the 4th pillar? Sounds like a newer one.
It is, relatively. Pillar 4 is the SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors. Drugs like dapagliflozin and empagliflozin. These were originally diabetes drugs, which is fascinating. They work in the kidneys, making you excrete more glucose and sodium in your urine. This helps reduce fluid volume, takes load off the heart, lowers blood pressure a bit.
And they work even if you don't have diabetes.
That's the remarkable thing, yes. Major trials showed they significantly reduce cardiovascular death and heart failure hospitalizations in patients with HFrAF, with or without diabetes. They also have a significant benefit in protecting kidney function, which is often also impaired in heart failure. It's been a real game changer adding these to the mix. Main side effects are things like urinary tract or yeast infections, and a small risk of a rare condition called euglycemic DKA in diabetics.
Wow, 4 pillars. That's a powerful combination. Are there other meds too?
Yeah, there are others. For certain patients, especially African Americans who might not tolerate or respond fully to ACE or Barney, a combination of isorbide dinitrate plus hydralazine has shown a mortality benefit. There's ivabradine for lowering heart rate in specific situations. And very importantly, for patients with a persistent consistently low EF, usually 35% or less, an implantable cardioverter defibrillator, ICD, is often recommended to prevent sudden cardiac death from dangerous arrhythmias, sometimes special pacemakers too for coordination.
So with all these helpful drugs, what should people with heart failure definitely avoid taking?
Crucial question. The sources are clear on several things to avoid. Certain diabetes drugs called thiazolidinediones, TZDs or glitazones, can cause fluid retention and worsen heart failure. They're generally a no-go. Most calcium channel blockers, particularly the non-dihydropyridine ones like diltiazem and verapamil, should usually be avoided in HFrEF. They can weaken the heart's contraction and haven't shown a mortality benefit. Amlodipine is generally considered safer if needed for blood pressure or angina. A big one. NSAID's non-steroidal anti-inflammatory drugs like ibuprofen or naproxen and COX-2 inhibitors, avoid them. They cause sodium and water retention and can harm the kidneys. Big risk. And finally, combining an ACE inhibitor, an ARB, and an MRA, like spironolactone, together is generally not recommended because the risk of dangerously high potassium becomes too great.
That's really important practical advice. Okay, let's switch gears slightly to HFpEF, the preserved ejection fraction type. You said management is different and evolving.
Yeah, HFpEF has been trickier. For a long time, we didn't have therapies that clearly showed a mortality benefit like we did for HFrEF. The focus was more on symptom control and managing comorbidities, but that's changing. Lifestyle is still paramount. Exercise, sodium restriction, and aggressively managing those associated conditions is maybe even more critical in HFpEF. High blood pressure, atrial fibrillation, diabetes, obesity, kidney disease, getting those under control is key.
And the medications, are the pillars different?
The pillars look different, yes. The big breakthroughs have come recently. We now know that SGLT2 inhibitors, particularly empagliflozin, do reduce the risk of cardiovascular death or heart failure hospitalization in HFpEF patients too. That's huge. And MRAs like spironolactone are also recommended, particularly for patients with elevated natriuretic peptides, to reduce hospitalizations. So for many HFpEF patients now, especially NYHA class 2 with higher BNP levels, the recommendation is actually first-line treatment with both an SGLT2 inhibitor and an MRA. Diuretics are still used as needed for fluid overload, of course.
What about the other drugs used in HFrEF, like RNIs or beta blockers?
That's the interesting part. Unlike in HFrEF, drugs like RNIs, sacubitril valsartan, ACE inhibitors, ARBs, and beta blockers are not routinely recommended for all HFpEF patients just for the HFpEF itself. They might be used if the patient has another reason to be on them, like using an ACE or ARB for coexisting diabetes or kidney disease, or a beta blocker for atrial fibrillation or coronary artery disease. An ARNI might be considered if blood pressure is still high despite other treatments, but it's not a universal first step like in HFrEF.
So a much stronger focus on SGLT2s, MRAs, and managing everything else going on.
Exactly. Treat the comorbidities, use SGLT2Es and MRAs for the HFpEF itself, and manage fluid overload with diuretics. It's a more targeted approach than it used to be.
Okay, one last major area. The acute situation. When things flare up badly, acute decompensated heart failure, ADHF, what usually causes that?
Yeah, ADHF is essentially a sudden worsening of heart failure symptoms, often leading to hospitalization. The most common triggers, honestly, are often related to treatment. Things like dietary indiscretion, eating too much salt, or stopping or reducing heart failure medications, even just decreasing physical activity sometimes. Other big triggers are uncontrolled high blood pressure, developing an abnormal heart rhythm like atrial fibrillation, AFib, infections, or having another heart problem flare up. Often it's a combination.
And the symptoms are just much worse versions of the chronic ones.
Pretty much. Much worse, shortness of breath, maybe needing to sit bolt upright to breathe. More lung congestion, louder crackles, worsening leg swelling, abdominal bloating. In the most severe form, cardiogenic shock, the heart is failing so badly that blood pressure plummets and vital organs aren't getting enough blood flow. That's a true emergency with confusion, cool, clammy skin, low urine output.
How is it diagnosed quickly in the hospital?
In the acute setting, it's largely based on recognizing those signs and symptoms rapidly. But tests help confirm and assess severity. Biomarkers like BNP or NT-proBNP are usually very high. A chest X-ray is key to see the extent of lung congestion. You might see fluid shifting upwards in the lung fields, cephalization, lines indicating fluid between lung tissues, curly B lines, or even that classic butterfly pattern of fluid around the heart. An ECG looks for triggers like AFib or ischemia. And an echocardiogram is usually done quickly, too, to assess heart function and rule out acute mechanical problems.
And the immediate treatment, what's the focus?
The immediate goals are to stabilize the patient, relieve the congestion, and improve oxygenation. First line is usually intravenous loop diuretics, like furosemide, given quickly to help pull off that excess fluid. This usually provides rapid symptom relief. Having the patient sit upright, maybe with legs dangling, can help reduce the amount of blood returning to the overwhelmed heart, preload. Supplemental oxygen is given if oxygen levels are low. Sometimes non-invasive ventilation like CPAP or BiPAP can really help. It pushes air into the lungs, helps keep airways open, reduces the work of breathing, and can prevent the need for intubation.
What if diuretics aren't enough or blood pressure is an issue?
If diuretics alone aren't cutting it for breathlessness, IV nitrates like nitroglycerin can be added. They help relax blood vessels, especially veins, which further reduces preload and eases congestion. Can't use them with recent PDE5 inhibitor use, though. If the patient is hypotensive in that cardiogenic shock state, then we need to support blood pressure. This might involve positive inotropic agents drugs like dobutamine or milrinone, which temporarily boost the heart's contractility, or vasopressors like norepinephrine to constrict blood vessels and raise pressure. But it's crucial to remember these inotropes are generally a temporary bridge. Long-term use is associated with increased mortality, so you use them to stabilize, then try to transition off as soon as possible.
And what about those beta blockers during an acute episode? Hold them.
Yes, that caution we mentioned earlier is really important here. While beta blockers are essential for long-term HFrEF survival, during an acute decompensation, especially with significant volume overload or low blood pressure requiring inotropes, beta blockers are typically held or reduced. Starting or increasing them in that acute, unstable phase can sometimes worsen things. You cautiously reintroduce or increase the dose once the patient is stabilized and less congested.
Wow. Okay. What an incredible journey through such a complex condition. From understanding the subtle differences between HFrEF and HFpEF to the body's own responses becoming problematic, and then these really sophisticated multi-pronged treatment approaches.
Yeah.
It's a lot.
It really is. And if we connect this to the bigger picture, it just highlights the massive strides medicine has made. Heart failure used to be, well, pretty bleak. Now, while it's still a serious chronic condition, with early diagnosis, the right classification, and applying these evidence-based therapies, both lifestyle and the pharmacology, it's become a manageable condition for so many people. The understanding of the pathophysiology and the targeted treatments really have transformed outcomes.
Absolutely, which makes you wonder. We've seen how drugs like SGLT2 inhibitors, originally for diabetes, completely changed the game for both HFrEF and HFpEF. Medical understanding is clearly still evolving rapidly. So this raises an important question, doesn't it? How might personalized medicine really tailoring treatments based on someone's individual genetic profile, their specific biomarkers, their unique physiology? How might that further revolutionize heart failure care in the future?